73-year-old Margaret sat in the waiting room of her local orthopedic clinic, expecting the same personalized care she received for her left knee replacement 5 years ago. Instead, her consultation for the right knee lasted barely 7 minutes, ending with a rushed scheduling for surgery and a mandated physical therapy plan at a facility across the hall. Margaret did not know that her trusted independent surgeon was no longer the boss. The clinic had been quietly bought by a private equity firm, transforming a community healing space into a high-speed revenue generator. Orthopedic surgery and physical therapy are the latest highly lucrative frontiers for private equity investment. Over the past decade, billions of dollars have flooded into this specific medical sector, fundamentally altering the patient experience and the community-based nature of orthopedic medicine. As one investigates the trend of rolling up independent surgical practices, a disturbing reality emerges. Firms are aggressively hunting for independent surgical practices, recognizing that bone and joint care offers a reliable, aging demographic with predictable Medicare and private insurance payouts. The private equity playbook here relies on a strategy known as a roll-up acquisition. Firms purchase a large, successful platform practice and then systematically acquire smaller, independent orthopedic clinics in the surrounding region. By merging these smaller entities into massive regional corporate platforms, the firm eliminates local competition and consolidates market power. This allows them to negotiate higher reimbursement rates from insurance companies simply by controlling the regional supply of orthopedic surgeons. The true financial prize lies in capturing what the industry calls ancillary medical revenue. When a private equity firm buys an orthopedic practice, they are not just buying the surgeon's time in the operating room. They are buying the entire life cycle of the patient's injury. This means rolling up physical therapy services, magnetic resonance imaging machines, and durable medical equipment dispensaries under one corporate umbrella. Every step of the patient's recovery becomes a distinct monetized transaction feeding into the firm's bottom line. For the doctors, this orthopedic practice consolidation marks a stark loss of independent surgeon autonomy. Physicians who once owned their practices and set their own patient loads are transitioned into employees bound by rigid corporate contracts. These contracts often come with strict surgical volume targets, tying physician compensation and bonuses to the number of procedures performed or the amount of ancillary services billed. The pressure to produce shifts the focus from conservative, patient-centered management to aggressive, high-margin interventions. Medical ethicists warn that this volume-driven environment inherently conflicts with the Hippocratic Oath. When a surgeon's livelihood depends on meeting corporate quotas, the threshold for recommending surgery can subtly lower. A patient with mild osteoarthritis might be nudged toward a joint replacement rather than being encouraged to try weight loss and non-surgical interventions first. The financial architecture of the private equity platform demands constant, accelerating throughput to satisfy investors who expect rapid returns. To finance these massive roll-ups, private equity firms utilize a leveraged buyout model. The firm uses a small amount of its own capital and borrows the rest, placing the massive debt burden directly onto the balance sheet of the newly acquired orthopedic platform. The clinic itself must now generate enough cash flow not only to cover its operating expenses, but to service millions of dollars in high-interest corporate debt. The shadow of that debt strategy quickly alters the clinical environment. To meet aggressive debt obligations, management implements sweeping cost-cutting measures. Experienced, higher-paid physical therapists are replaced with lower-cost assistants or technicians. Appointment times are compressed, forcing therapists to treat 3 or 4 patients simultaneously in a crowded, chaotic gym setting. The quality of rehabilitation degrades as the focus shifts entirely to maximizing the daily billing census. Patients recovering from complex spinal fusions or rotator cuff repairs find themselves navigating a factory-like rehabilitation process. Instead of receiving hands-on, individualized therapy, they are often parked on stationary bikes or given generic exercise sheets while the understaffed clinic attempts to process the sheer volume of bodies. The physical therapy services, once a crucial component of a tailored recovery plan, are reduced to an automated revenue stream that prioritizes volume over actual healing. How do non-medical financial firms legally own and direct medical practices? They exploit a massive loophole in the corporate practice of medicine laws, which were originally designed to prevent corporations from influencing medical decisions. Private equity firms bypass these protections by creating management service organizations. The firm technically only owns the administrative side of the clinic, but through complex contracts they control the finances, the staffing, the equipment, and the operational metrics, effectively dictating clinical care from the shadows. With the management service organization firmly in place, the firm seeks to maximize a metric known as EBITDA, which stands for earnings before interest, taxes, depreciation, and amortization. To inflate this number, executives often mandate the use of specific, higher-margin surgical implants or push for procedures to be done in their own ambulatory surgery centers rather than hospital outpatient departments. These ambulatory centers are highly profitable, capturing facility fees that would otherwise go to a traditional hospital. This aggressive capture of facility fees and ancillary services drives up the overall cost of healthcare for everyone. As private equity platforms monopolize regional orthopedic care, they force insurers to accept higher prices, which are inevitably passed down to patients through higher premiums and staggering out-of-pocket deductibles. A community that once had a competitive market of independent clinics now faces a single profit-maximizing corporate entity controlling all bone and joint care. Whistleblower testimonies from former clinic administrators paint a grim picture of the internal culture. Administrators report receiving weekly, sometimes daily, dashboard reports highlighting which surgeons are falling behind on their surgical volume targets or failing to refer enough patients to the in-house physical therapy wing. Doctors who resist the corporate push for higher utilization face intense administrative pressure, threats of termination, or severe financial penalties that threaten their livelihoods. Further extracting value, firms frequently execute a tactic known as a dividend recapitalization strategy. If the orthopedic platform is generating strong cash flow, the private equity owners will force the clinic to take on even more debt. The proceeds from this new loan are not used to buy better diagnostic machines or hire more specialized nurses. Instead, they are paid out directly to the private equity investors as a special, immediate cash dividend. The echoes of that capital extraction resonate through the physical infrastructure of the clinics. Because the cash was siphoned off to investors, the practice is left starved of operational capital. Essential diagnostic equipment is pushed past its useful life, waiting rooms become dilapidated, and the administrative staff is stretched dangerously thin, leading to catastrophic billing errors, delayed pre-authorizations for urgent surgeries, and severe patient frustration. Healthcare economists observe that the private equity horizon is inherently short-term, typically lasting only 3 to 7 years. The ultimate goal is never to build a sustainable, generational medical practice. The objective is to inflate the clinic's perceived value through aggressive consolidation and cost-cutting, and then sell the entire platform to a larger private equity firm or a massive healthcare conglomerate at a massive premium. This relentless cycle of buying, stripping, and flipping treats essential medical infrastructure like a distressed real estate asset. When the platform is finally sold, the original private equity firm walks away with a staggering return on investment. The orthopedic practice, however, is left saddled with compounding debt, a burned-out medical staff, and a tarnished reputation within the local community that relied upon its once stellar care. Federal regulators have historically failed to intervene in this specific type of consolidation. Because private equity firms acquire these independent clinics through dozens of small, incremental purchases, the transactions usually fall below the $119.5 million financial threshold that triggers mandatory antitrust review by the Federal Trade Commission. These stealth roll-ups allow firms to monopolize local healthcare markets completely undetected by federal watchdogs. The human cost of these stealth monopolies is devastating for patients experiencing post-surgical complications. When a patient develops an infection or a poorly fitted joint requires revision, the corporate structure often proves rigid and unresponsive. Patients describe being trapped in an endless loop of automated phone systems and offshore billing departments, unable to reach the surgeon who operated on them because the physician's time is strictly rationed by corporate scheduling algorithms. We are witnessing the systematic dismantling of the traditional doctor-patient relationship in orthopedic medicine. Trust, which is the bedrock of any healing environment, is replaced by a transactional, high-throughput model designed to satisfy distant shareholders. When a patient's pain is viewed primarily as an opportunity for ancillary billing, the core mission of healthcare is fundamentally corrupted, leaving vulnerable populations at the mercy of financial engineering. Policy advocates argue that without immediate transparency and stricter enforcement of antitrust laws, The independent orthopedic surgeon will become virtually extinct. The aggressive expansion of corporate platforms threatens to standardize a model of care where financial algorithms, rather than medical necessity, dictate who gets surgery, where they recover, and how much they are forced to pay. The industry is changing so rapidly that patients are often unaware of who truly owns their medical care. The quiet transformation of local bone and joint clinics into private equity assets demands urgent public scrutiny. Behind the glossy waiting rooms and the streamlined branding lies a calculated financial engine that prioritizes profit margins over patient outcomes. As corporate platforms continue rolling up independent surgical practices across the nation, patients must navigate a fractured system where their physical recovery is merely a line item in a leveraged buyout.